All right, welcome everyone to another episode of the group chat. We're so glad you're here with us today. Just some housekeeping items before we get started. You should see a little Q&A button on your screen. Feel free to submit questions throughout the presentation. At the end, I'll gather them and ask them to our presenter. This presentation is being recorded. However, no attendees will be identified. All images used in this presentation are the property of their respective owners. And as a reminder, the information shared during today's presentation is not medical advice, but we will be sharing additional resources at the end of today's chat. So with us today, we have Dr. Saad Javed. Dr. Javed serves as the Director of General Gastroenterology, Neurogastroenterology, and Motility for the Allegheny Health Network. He's here with us today to share his knowledge on irritable bowel syndrome. So without further ado, I'll pass it over to him.
Thank you so much for inviting me. I appreciate it. Our goal and hope today is that together we'll be able to understand a little bit more regarding this condition that's called IBS, irritable bowel syndrome. Hopefully, I'll be able to share the burden of this illness, the causes behind IBS, how we diagnose and manage this condition, and how there are options out there, including medical as well as non-pharmacological, that can help our patients. So without further ado, let's get into it. IBS is most certainly not a wastebasket diagnosis or a diagnosis of exclusion that was just given to patients because they have unexplained GI symptoms. Many researchers have actually spent most of their careers trying to unravel the cause of IBS and find treatments for the millions of sufferers. It is a real digestive disorder characterized by chronic abdominal pain and altered bowel habits in the absence of structural or anatomical causes. The Rome Foundation is a multinational group of scientists and clinicians that defines the criteria for IBS diagnosis. And the criteria basically involves recurrent abdominal pain at least one day a week in the last 3 months, linked to defecation, or change in the frequency or appearance of your bowel movements. This diagnostic framework has not only opened doors for more research, but has also helped remove a lot of stigma and has streamlined how care providers can approach IBS. Just to give you a little insight into the burden of this condition, IBS is a chronic, often debilitating GI disease that affects up to 1 in 10 people in the world's population. As many as 45 million Americans struggle with IBS symptoms. And according to some estimates, up to 40% of all visits to GI clinics, all gastroenterologists, would be due to IBS symptoms. When direct medical expenses and loss of productivity from missing work are combined, some estimates suggest that IBS can cost about $21 billion annually. There was a survey several years ago where we asked the burden of symptoms from IBS patients, and they mentioned that they would be ready to compromise or give up to 10 to 15 years of their life expectancy just to get some cure or comfort from the symptoms of IBS. So it definitely is taking a toll on us as a community. Despite extensive research, a unifying cause for IBS may not be very evident. Having said that, it is now established that the brain and digestive system are very closely linked, more so than any other organ system. So understanding this brain-gut axis dysregulation as a driving force for many of the symptoms of IBS has led to a paradigm shift in the management of this condition. There are several possible causes that can be implicated. Some symptoms can really be precipitated by abnormal motility patterns or spasms, uncontrolled contractions within the muscles of our gut. And that may explain why certain IBS treatment approaches, for example, antispasmodic medicines, can help regulate the contractions of the colon and can help relieve symptoms of pain as well as diarrhea. Many recent studies have revealed that a major component could be what we call visceral hyperalgesia or visceral hypersensitivity. This basically is this heightened sensitivity of nerves that supply the intestines. The thinking is that nerve endings in the gut perceive and relay excessive and painful signals to what would otherwise be normal stimuli like gas or stool or passage of food and stool through our gut. But our body perceives those otherwise normal signals in a very heightened fashion. And that is why some patients with severe IBS symptoms feel better once we give them neuromodulators, medicines that decrease the pain perception within our digestive system. Some patients with predominantly diarrheal or bloating symptoms may also have a condition called small intestinal bacterial overgrowth, where there is surplus of bacterial colonies inside the small intestine. What's unclear is whether SIBO can be a cause of IBS or whether IBS is precipitating because of excessive bacterial growth. Some patients with IBS hence will respond to antibiotic treatments that is focused on managing this bacterial overgrowth in the small intestine. In the same way, I would also mention that anxiety, sleep problems, phobias have also been shown to be independent risk factors for development of IBS. Additionally, food intolerances, recent infections, and inflammatory processes in the wall of the gut, genetics have all been implicated in the genesis of IBS. I would like to mention that certain meta-analyses, certain studies recently confirmed at least a correlation, if not causation, associated with adverse childhood experiences like abuse, mental illnesses, domestic violence, which again supports a biopsychosocial perspective for the pathophysiology or the cause behind IBS. So the role for early life adverse events is being explored as well as a potential risk factor behind a lot of the symptoms for IBS. So I think this is probably a good time to talk a little bit about why we are talking about IBS in the context of women's health. And I will say that overall, IBS has higher prevalence in women more so than men, with a female to male ratio of 2 to 1 in terms of those who seek medical care. Female patients may also be more likely to have constipation predominant IBS symptoms as compared to male patients. Additionally, certain coexisting conditions make managing IBS more challenging in female patients. For example, conditions like fibromyalgia, chronic fatigue syndromes, functional dyspepsia, psychiatric disorders like depression, anxiety, and somatization are often seen more frequently in female patients. When you think about it, there are multiple reasons why female patients might be more impacted by GI issues than men. Factors like menstrual cycle, hormonal changes throughout a woman's lifetime, pregnancy, childbirth, and menopause can all impact GI symptoms, right? Stigma around gut health is definitely a factor in terms of barrier to care for female digestive disorders. We've also found that there's definitely a higher prevalence of gynecological disorders like pain associated with menstruation, also called dysmenorrhea, and premenstrual distress syndrome has been described in women with IBS as compared to those without IBS. Interestingly, there was also a study where we found out that 1/3 of women with IBS describe symptoms that are very consistent with what we call chronic pelvic pain in these female patients as well. Interestingly, 32% of female patients with IBS have also reported symptoms of sexual dysfunction. So, a lot of overlap between IBS and other women's health issues as well. Um, in the same breath, I would also mention many of my patients ask me, can symptoms worsen during pregnancy? And for several reasons, the data related to pregnancy and bowel function are extremely limited. Surveys of pregnant women indicate that GI symptoms are very much common during pregnancy, and upwards of a third of pregnant women experience increased constipation, particularly in their second and third trimesters. Um, Many women report increased heartburn and nausea during pregnancy as well. So changes in the ovarian hormones, which are elevated during pregnancy, the physical pressures of growing a baby inside your belly, which places pressure onto the bowel wall, may all contribute to these digestive symptoms being aggravated or heightened during pregnancy. For many women, unfortunately, pregnancy can be a time of heightened stress and can exacerbate their already present symptoms of anxiety and depression, which can then lead to this vicious cycle of IBS symptoms getting worse. Again, this is an area that is somewhat poorly understood and needs a lot more studies. Before I finish, the slide, I would highlight that let's not forget that the uterus and the ovaries are very close to our colon and small intestine. So for female patients who have had surgeries in the pelvic region, C-sections, ovarian surgeries, hysterectomies, it is common to develop digestive issues down the lane. Um, I always tell my fellows and my trainees that healthcare providers need to remember this. This can all affect our digestive symptoms adversely. It can lead to abdominal pain, constipation, lack of bowel control, hemorrhoids, and pelvic organ prolapse in female patients, all of which can worsen many symptoms of IBS down the lane. So moving forward, coming back to our IBS, IBS is often subcategorized based on the most common type of bowel movements experienced, the predominant bowel symptom that these patients report. And these include IBS with constipation predominant symptoms, IBS with diarrhea predominant symptoms, and IBS with mixed symptoms. It's not just about labels, it's also affecting the predominant pharmacological therapies that we are able to offer patients for management of IBS. So it's important to know about patients' history and what are the predominant symptoms. While I'm saying that, I will also mention that it is not uncommon for patients who have one IBS subtype to vacillate or oscillate between other subtypes as well. So originally, the diagnosis of IBS or irritable bowel syndrome over the course of decades was thought to be a diagnosis of exclusion, which implied that IBS was valid only if other disorders that may be causing symptoms were essentially ruled out. Today, gastroenterologists and healthcare providers agree that while tests are often important to rule out diseases like celiac disease or inflammatory conditions like Crohn's disease or colitis, these tests should only be limited to those who necessarily need them based on symptoms and medical history. IBS remains a specific condition that can be confidently diagnosed based on good understanding of patients' symptoms and following a good history and physical examination in the absence of alarm signs. I would take an extra minute here and say this again. There is a lot of consensus and data from existing studies which show that a low diagnostic yield for additional workup in several subtypes of IBS, particularly without alarm features. There is minimal impact on patient outcomes or patient satisfaction with excessive amount of workup. So extensive testing is unlikely to uncover new information sometimes, and despite our best intentions, excessive testing often does not actually reassure patients of their IBS diagnosis. And this approach is endorsed and recommended now by the American College of Gastroenterology in their guidelines. I firmly believe that not delaying care and by giving positive diagnosis, we can lead to improved patient outcomes by giving patients a better understanding and a reassurance in this knowledge. This really allows patients more acceptance in their diagnosis. It allows early adoption of better and effective therapies. Okay. I will now move on to the management of IBS. I will say that you may find ads or influencers on your social media in this day and age using marketing phrases like miracle pill for IBS or cure for your gut or what your doctor is not telling you. I do recommend to my patients to not fall for these. When it comes to IBS, there really is no one quick fix. The key to achieving relief is to embrace the understanding of IBS as a lifelong chronic condition in which multiple factors are contributing to development and triggering of symptoms. So every patient is unique and warrants a very compassionate, individualized therapy strategy. We often start with easiest and safest steps, for example, dietary changes. We can use integrative ideas like natural and herbal remedies, and then move on to medicines aimed at reducing pain as well as either alleviating diarrhea or constipation based on what the overarching symptoms are. Finding a plan that works can take time, patience, and a lot of times experimentation. And IBS management will never be a one size fits all. The path to feeling your best will often involve a coordinated multidisciplinary approach. That is the value of integrated medical centers, where typically combined experience of dietitians, therapists, gastroenterologists tends to come together to provide a variety of evidence-based treatments. Um, Given the intertwined roles of brain and the gut, there are several behavioral therapies that have emerged as being effective to help treat symptoms of pain that are arising from these complex pathways. Cognitive behavioral therapy, CBT, for example, is known to address stress, negative emotions, and co-occurring depression and anxiety in these patients. This allows patients to unlearn the negative thoughts and behavioral patterns that have evolved due to their digestive symptoms sometimes. We'll talk about gut-directed hypnotherapy as a viable options, which has been validated recently in studies. Mindfulness-based stress reduction engages in regular practical practices of emotional and physical relaxation, skills which in turn can decrease the awareness of abdominal symptoms. In addition, there are some other modalities like diaphragmatic breathing, abdominal massages, pelvic floor with biofeedback, which are all options that a doctor should be able to explore with their patients. We'll talk a little bit more regarding the role of food in the management of IBS. So let's come to that. There are several drivers of how food can trigger digestive symptoms in IBS. What you are eating can affect your intestinal motility. It can modulate visceral sensation. It can unfavorably change the gut microbiome and can potentially activate immune response within your GI tract. So one of the diets that has been explored again and again and validated over the course of years is a diet that is low in FODMAPs. All right. FODMAPs basically stand for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. These are basically carbohydrates that are poorly absorbed in your intestines. And a low FODMAP diet has been shown to be effective in alleviating symptoms of abdominal distress in as many as up to 80 to 90% of patients who are struggling with IBS. Better outcomes are shown in symptoms like abdominal pain, bloating, constipation, but diarrhea as well as flatulence. This can be a particularly challenging diet because it can be highly restrictive, particularly in its early phases. So it is vital to work with a gastroenterologist and or a registered dietitian who can ensure that following the diet is uh, being followed. And then it is crucial to start to reintroduce some of these dietary elements back so that we are able to maintain proper nutrition and we can maintain sustainable responses. Just to give you a little insight, on the left-sided panel, I've copied some high FODMAP options in the red, and on the right-hand panel, you're seeing some low FODMAP options, which are better alternatives and are better tolerated in our patients with IBS. There is a lot that is being explored in terms of the role of food in IBS. And hopefully in the coming few years, we'll have a better understanding of how food is triggering some of these symptoms and how we can use food as medicine in the management of IBS. I had briefly talked about the role of gut-directed behavioral therapies earlier. I would like to go a little bit deeper into the role of these modalities. Now, remember that pain is a uniquely modifiable experience. It is interpreted and coped with in different ways in different patients. And I mention this because, in addition to pharmacotherapy, medicines, pills, when dealing with these challenges of a chronic lifelong illness, what disorders, these disorders of gut-brain interaction, we as providers always think about what else can we offer in addition to drugs. Can we modify cognitive factors? Can we help the patient with their mood and hypervigilance? Because these psychosocial factors can upregulate the pain signals. And the expression of pain changes and hopefully can be modified if we approach pain associated with IBS more holistically. Gut-focused hypnotherapy is a highly adaptable and effective treatment for refractory disorders of gut-brain interaction. It can be customized based on patient symptoms. It has consistently shown to be superior to standard medical therapy, and it adds the advantage of improved extraintestinal symptoms as well. Basically, we are improving psychological and cognitive function. We improve quality of life, as well as better healthcare utilization is achieved. Within our network, I work very closely with behavioral health consultants within our network. Um, our pain medicine program offers an empowered relief program, which is a web-based therapy to manage patients with the highest symptomatic burden of pain. There are now apps on your phone or computers that can be used to help provide hypnotherapy aimed at gut symptoms. I will wrap up now. I will say that I hear from my patients all the time about this sense of despair in the face of their chronic illness. It seems to them that no one is understanding their illness. Treatments often tend to be fickle and sometimes unreliable. There is a level of frustration when we are experimenting with different drugs and their doses. They often start to believe that recovery from IBS is unachievable. And I will say that establishing a fruitful patient-doctor partnership, exploring various options can really help can result in symptoms that are less frequent and less severe. Our goal is always reduction in some symptoms to begin with, and then maintaining that journey. IBS is chronic. Patients struggle, and their pain does not need to be chronic. Our knowledge and understanding of this condition is rapidly evolving, and hopefully, over the next several months and years, more studies will emerge that can reveal further interventions that can help enhance patients' quality of life, their sense of well being, their capacity to engage in their activities of daily living successfully. With that, I come to a conclusion to today's talk. Thank you for your time and attention.
Thank you so much. That was wonderful. We're now going to get into our Q&A portion. So if you'd like to submit a question, go ahead and use either the Q&A box or the chat box. To start us off, what is the difference between IBS and IBD?
Yeah, that's a great question. Thank you. IBS is based in these concepts of visceral hypersensitivity, altered gut motility, dysbiosis in the gut microbiome. IBD stands for inflammatory bowel disease. These are very distinct inflammatory conditions, autoimmune conditions that affect our gut. The two big ones are Crohn's disease and ulcerative colitis. Ulcerative colitis is this autoimmune inflammation of our large intestine, also called the colon, and hence the word colitis, inflammation of the colon. Crohn's disease is this inflammatory condition which is similar in its pathogenesis, but can affect the rest of the gut anywhere from our mouth to our bottom, can often include our small intestine. These conditions can lead to a lot of inflammation, pain, altered bowel habits, including diarrhea, blood in the stools, and these conditions are treated with anti-inflammatory medicines, medicines that suppress the uh, gut inflammation. It's a very different pathophysiology. In the same breath, I will also mention that there is definitely an overlap in patients who have IBD or colitis and Crohn's to have symptoms of IBS. In fact, it is not uncommon for me to be involved in the care of these patients along with my IBD expert colleagues to co-manage their symptoms of IBS in addition to IBD. We know that conditions like Crohn's and colitis affect our gut microbiome, intestinal wall permeability, and so on. So these patients by default are at a high risk for developing coexisting IBS symptoms. So they are, by virtue of their pathophysiology, very distinct entities, IBS versus IBD, but they can coexist.
Thank you. And just in case anyone needs to drop, do you mind going forward a couple of slides? Perfect, right here. In case anyone needs to drop, just sharing some information on our upcoming sessions. Next month, we'll have gynecologic cancers. And then in August, oh, that's supposed to say September, we'll be discussing uterine fibroids. So that QR code right there will take you to the registration page if you'd like to sign up. If you would like to book an appointment at AHN, you can visit our website or call the number on your screen. And if you just want to learn more about our GI program and different program offerings, please feel free to scan that QR code. All right, jumping back into the questions. How does IBS affect the gut microbiome, and can probiotics or herbal remedies help?
Yeah, thank you for asking that question. The role of gut microbiome is being explored and researched very, very aggressively in our community, in the GI world. I briefly mentioned small intestinal bacterial overgrowth, so I'll touch upon that one more time, and then I'll talk about the role of probiotics as well. We all have a normal gut microbiome. The problem here becomes everybody's normal is different, and to this day, we still don't know what is the right microbiome for individual patients. When we say gut microbiome that's normal, these bacteria grow and tend to grow in our large intestine. It is when these bacterial colonies overgrow or overproliferate in the small intestine when we start to experience some effects, for example, excessive bloating, flatulence, abdominal distension, pain, altered bowel habits, sometimes diarrhea, and so on. Um, there's a certain variant of intestinal microbial overgrowth where methanogenic organisms are overgrowing. There are organisms that make a lot of methane, and that can lead to constipation predominant symptoms. And that's when we diagnose this condition with a possible breath test, where we measure the amount of hydrogen and methane as surrogate markers for the proliferation of bacteria in our gut. This condition can be treated with antibiotics and modification of your diet. Uh, what is the role of probiotics in management of IBS? It's $1 million question, and it does not have a short answer. To this date, there is not a singular probiotic that has been endorsed by large studies. The data is very mixed, and we as gastroenterologists are currently not in a position to endorse a singular probiotic for the blanket term that is IBS. Certain patients may benefit from probiotics that needs to be considered and talked about by their physician based on their symptoms. I do tell my patients if they are trying probiotics, and if they have been using those for several weeks or months, if they haven't noticed significant improvement, it is most likely an exercise in futility. These probiotics that are available in the market often tend to be exceedingly expensive. So I use them in my practice rarely, if at all, and only for short courses if patients are experiencing benefits.
Thank you. When should someone seek medical intervention for IBS symptoms?
Yeah, if IBS is starting to affect your quality of life, if the symptoms are causing psychological distress, if it's affecting your productivity, absolutely is the right time to talk to your physician. I don't think there's ever a bad time to seek care. I ask my patients, I educate my fellows, my residents to always encourage patients to seek care earlier on, because despite being a frustrating condition, there are options out there that can improve quality of life, improve patients' bowel habits, and can improve symptoms. So earlier on, the better, because that allows patients to have a good education and understanding of this condition, which then improves outcomes and decreases healthcare utilization in a positive way.
Thank you. Are there specific types of exercise that are better or worse for managing IBS symptoms?
Yeah, particular exercise that I will definitely talk about today is, particularly in the context of women's health and female patients, is pelvic floor physical therapy. Um, our pelvic floor is a group of muscles and structures within our pelvic area that support a lot of our organs. In the female case, they support the female reproductive tract, but in general, they also support the digestive organs as well. Due to history of C-sections, pelvic surgeries, history of difficult births, aging itself, hormonal shifts, menopause. A lot of patients start to develop what we call dysenergic defecation, where our pelvic muscles are not working in a coordinated fashion. That leads to a lot of bloating symptoms, a lot of incomplete evacuation, constipation, and so on. There are ways to diagnose pelvic floor dysfunction and dysenergic defecation, and once it's formally diagnosed, we can then work closely with pelvic floor physical therapists to follow biofeedback protocols, and that can really improve patient outcomes. In my practice, I have a very low threshold to diagnose patients with dyssynergic defecation and then refer them to pelvic floor physical therapy. It almost is like adult potty training, and it has exceptional benefits. So, in terms of exercises, those are the ones that really show a lot of improvement in patients who have obstructive defecation, pelvic floor dysfunction, and so on.
I think that actually was our last question. So I just want to thank everyone for joining us today. We'll hope you'll join us for another episode of the group chat. And thank you, Dr. Javed, for being here and sharing all your expertise. We appreciate it.
Thank you for the invitation. I appreciate it. Have a great day.
Have a great day.